So welcome, and thank you for joining today's Medline Canada sponsored presentation, and welcome to the virtual audience as well. My name is Shelley Masluk. I'm the Director of Clinical Engagement with Medline Canada, and I'll be your moderator today for this session. We'd like to thank Wounds Canada for the opportunity to educate, as well as virtually. We also want to thank all of you for joining the presentation today. Today, the Medline Canadian team is very excited to welcome Rosemary Hill, our guest speaker. Her presentation is entitled Facing Multiple Skin Challenges, Proven Practices that Improve Clinical Outcomes. In her presentation, Rosemary will share a few of the skin challenges she has faced in her practice and offer solutions that have worked for her and improved patient outcomes. During her presentation, I encourage our virtual audience to input any questions you have into the Zoom Q&A at the bottom of your screen. For our in-person audience, please use one of the floor mics to address your questions during our Q&A portion at the end of Rosemary's presentation. Now let me tell you about Rosemary Hill. Rosemary has been a nurse for over 35 years and works full-time as a certified nurse specialized in wound ostomy incontinence at Lionsgate Hospital in Vancouver Coastal Health in British Columbia. In 2004, she completed her wound ostomy continence program at Emory Medical University in Atlanta, Georgia, and has been practicing within that role. Her past volunteer activities include a 2-year term as president of Nurses Specialized in Wound Ostomy Continence Canada from 2016 to 2018. And in 2019, she traveled to Argentina with a group of Canadian NSWACs to offer wound education. She currently participates on both the Skin and Wound and Ostomy BC provincial committees. All of her experiences in wound and ostomy care have provided her with opportunities to speak nationally and internationally. She was the recipient of the Award of Excellence in Practice from the Association of Registered Nurses of British Columbia. It is now my honor and pleasure to introduce and welcome Rosemary Hill.
Thank you, Shelley, for that introduction. You know, I just want to take a minute to thank Wounds Canada and their board for being brave and taking the time to say, yes, let's have a conference where we meet together face to face. It's been a while. And yet we have the joy also of people joining in virtually. And I'll try to make sure that I'm remembering all of those hundreds of people across our country and maybe further afield listening in. So thank you, Wounds Canada. And thank you, Medline, for giving me this chance today. You know, I've missed getting together at conferences. It's been, well, getting near to 3 years. And when I look back, when I go to conferences, I realize those conferences, I learned a lot from speakers, there was networking, but when I went back home to the hospital and to my patients, I was able to bring something back, and I have really missed that. So I'm excited about these next few days, where once again, I feel that I'm gonna be inspired because there's a wonderful group of people here in terms of speakers, topics. So really, really excited about the next few days. Now, when I'm thinking across the country and our virtual people, I immediately think back to my home province of BC, who at this point, they're just like waking up. So they're just kind of surfacing as I am a little bit today. So that, because I'm just that 3 hours behind. So if there's a little skip on a word or two, there'll be some forgiveness. But what I might tell you is I stopped at that Sage booth and I mentioned that little time difference. And they said to me, aha, we have the refresher for you. So I had a lovely, absolutely little fragrance of refresher and very nice stuff. So I'm going to just encourage you all to stop by that and check that out. Anyway, let's get on, and I'm going to watch the time, and Shelley knows she's going to give me some cues if I'm chatting a bit too much. I start this morning with a picture that I took at Stanley Park, if any of you have been to Vancouver, and it was in the fall where the colors were changing. And I felt that was very reminiscent of, in a way, of what we've been through these last few years. There's been a lot of changes and challenges, and we've had to make some tough choices. And so, that was hence the picture there. But and in that, there have been skin challenges, and we've had to kind of quickly, as our Dr. Bonnie Henry says, pivot and say, how can we manage this quickly, effectively, and simply? So that's what this next session is about. So let's talk about some skin challenges that we face, and maybe, I believe, some proven practices that will improve our clinical outcomes. Now, let me try this little clicker. And I disclose that I'm a consultant for Medline today. So our objectives are, we're going to look at the prevalence of some really common skin challenges like peristomal skin damage. I'm hoping there's some NSWACs in the group, some nurses specialized in wound ostomy continence care, and we're going to see a little bit on ostomies. We're going to also talk about incontinence-associated dermatitis and skin tears. Skin tears, primarily type 1. And we're going to look at how we use cyanoacrylate for skin protection. And then we're going to just illustrate the use of the cyanoacrylate marathon with some case studies. And then I later want to end with talking about a proven skincare regimen, and in terms of both treatment, but prevention. We want to think prevention as well. So when we look at skin challenges, we say, wow, we need a solution that's safe, simple, not painful, readily available, cost-effective, and doesn't require frequent application. You know, these last couple of years have been difficult. Actually, I don't know why I was reflecting on this, but I was realizing I graduated from Vancouver General Hospital in Feb 82 as a nurse. And so here it is, 2022. And I realize I've been nursing 40 years. And, but I will say the last 2.5 have been probably the more challenging. But you know, in it, there's been something unique in terms of the closeness I feel with my colleagues, that somehow we were deep in the trenches of something we had never experienced before. And so, and I know it's been tough, but I want to really inspire you here today and those out in the virtual world there that, you know, I want to keep going because of some of the special connections I've had with my colleagues that I don't think I would have experienced had we not had the pandemic. And so I'm a person who somehow wants to leave elements of inspiration and hope as we go forward. And, you know, I want a few more years. So you may even see me 45 years from now. But I want to share that with you because although it's been tough, there has been some uniqueness I've seen both in patients and people that I've worked with that has actually fueled me to say, I want to keep going. Anyway, let's keep moving on. I just want to throw those little, yes. All right, okay, now we're going to jump into some of those wound pictures, peristomal skin damage, really, really painful. And again, what I noticed was that a lot of patients would struggle at home because they weren't able to come to the hospital, and they would try all kinds of different things because they were scared to come. And so, and we know that the prevalence of peristomal skin damage is really substantial. Yes, the literature, it varies from anywhere from 10 to 70%. And in general, I see it more with my ileostomy and my urostomy patients. Let's jump into a case study of a 63-year-old gentleman. he recently had urostomy and ileal conduit, and he presented with really profound skin irritation, and you can just see it. And it was really painful. But, you know, to boot, this gentleman, he also had a colostomy. And he said to me, you know, Rosemary, I don't know how I'm going to do this if I have my colostomy and this is happening to my urostomy. What can I do? And so I said, well, first of all, we have to get the right fit. We have to find the right appliance for your stoma. But, you know, once I knew that he needed a certain fit, I had all of this wet skin, and you just can't sort of go, I know the right appliance and put it on because the skin is wet. And so this is where I reached for something called Marathon. It's that cyanoacrylate. I laid it on his skin and then put him in something with some convexity, and you can see the results thereafter. And he was actually heading to a rural community in BC. So I really wanted to get things stable because he said, who am I going to go to? How am I going to fix this? So it was important to get an intervention that was timely. So I'm not sure how many of you are familiar with something called Marathon, but we're pretty, I say we, Vancouver Coastal Health, Lionsgate Hospital, our NSWAC team reaches for it in certain instances that I want to highlight today. And one of them is the peristomal skin damage. So what is it? It is a no-sting barrier. It's applied as a liquid. It dries very quickly. It's 99% cyanoacrylate. And there's some of the science around the cyanoacrylate. It is different from those other things, such as a skin glue. But I want to mention to you my naivety, because in the beginning, when I used it, I would say to the patient, well, I have this thing it's really going to help. It's going to put a layer of protection. And you know what? Mistakenly, I used the word glue. It's not a glue. It's not like that special other glue that we know of, something like Dermabond or Skin Affix. The ingredients of Marathon are different. And I think perhaps the best way to describe that is with a picture. So when we look at our skin, a magnified view, and when we look at the comparison, say, of a no-sting skin protectant, and we look at Marathon, the cyanoacrylate, you can see it's a much thicker layer. The photo on my right, you can see it's a much thicker layer. So it affords us a level of strong protection. So I want to, now we've got 2 videos in my presentation today, so we'll see how this runs. And what I did was I didn't choose a patient with horrendoma skin. I just chose one where there was a beginning denudation and that I was going to demonstrate, because I thought, I want to show you in my clinic how I apply it. And so this lady readily agreed to the video. So guys, I'm going to hit the click button. I think that's what Damien said. And let's see if the video, no, I knew it. Okay, so I'll go back. Oh, okay. Damien, can you just run the video?
Okay,
I knew that.
I'm very glad you came today because you definitely,
I know.
had a little bit of leakage there, and we are going to fix your flange, but I'm going to use a little bit of glue
Okay.
on that skin that looks a little bit weepy and red. Let me just grab a glove here. And you know what the thing is, though? I think the bottom line is we have to sort out the cause. So we'll get your skin healing nicely,
Yeah.
but we're going to switch you into a little bit of convexity, I call it. And you know what, just to be on the safe side, I might have you come back in a bit just to make sure.
Yeah. Okay. Yeah.
that-
Good idea.
That's not a bad idea, hey?
No.
Okay, so we're going to take the ampule and I'm going to kind of crack it open. And the liquid, I squeeze it
Yeah.
and it dribbles into that foam. And now I'm going to actually just drip it on you.
Okay.
And then once I've dripped it, then I'm going to do a little bit of spreading because this thing can harden pretty quickly. Perfect.
Oh, I see.
All right.
Yeah.
And does that, it doesn't usually burn or
No,
anything?
I don't feel
Feel it.
anything.
Good. Okay, we'll let that dry before we start our process for
Okay.
our flange. Okay.
She's quite a good patient, hey? Did you catch that? No pain. But do you notice too her abdomen moving? So she does have a bit of a peristomal hernia. And I think that also contributed to her leakage, but she had a flat flange. So one of the things I want you to realize that, of course, the number one thing is you have to address the cause. Why is it leaking? But often the answer is you need to perhaps use convexity or a moldable ring. But often you know the right answer, but when their skin is so wet, you're not able to follow through. So that's where I find the Marathon is helpful. It gives you a dry platform. This was another case where his daughter actually is a nurse in the OR, and her dad has Alzheimer's and really struggling with an ileostomy in a care facility. And you can imagine they were really short-staffed, and emptying his pouch regularly was just tough. And so he was having leakage. But what happens is all he has to do is have 1 or 2 leaks, and then the skin, there's just that real chemical damage. So, and you know what? The pain for him was really tough. So they started him on narcotics, which we know is not really great for dementia, narcotics. So, but you can see how, again, putting the correct appliance, and actually in this instance, his appliance actually wasn't too bad. He had all the right features, but he had had a couple of leaks and the skin was damaged. And once that skin is damaged, it's hard to just go back to their usual poaching system. I also have another case of another lady who with, again, a urostomy. You'll see the cases I'm featuring. They're both ileostomy and urostomy, and those are the ones that are more plagued with peristomal skin damage. But again, all of the denudation around the stoma. 48 hours later, you can see the beginning of epithelialization, but look at that by day 8. Amazing, you know, and again, just modifying her pouching. And then I didn't see her for several years. So it's a relatively efficient fix with not multiple visits. Okay, so that was peristomal skin damage. Now we're going to look to another skin challenge, which I might add, I'm amazed at how many times I'm called for skin tears. And maybe in BC, we do have a larger elderly population, falls, many people on blood thinners with the resulting hematoma and a nasty skin tear. But let's look at this 95-year-old. And he was actually in our hospital, and that night there had been a fall. And so as the nurses were heading off shift, they said, "Oh, Rosemary, you've got to go see 625. And I said, "Oh, okay." And they said, "But don't worry. We steri-stripped him up. It's really good." And so, and so I looked at him and I thought, oh no. Anyway, it was still kind of moist. So I just took the time to very gently remove the steri-strips. You know, one thing that's changed in my scope of practice that wasn't there maybe 10 years ago was the adhesive removers. So in the ostomy world now, I just love all these lovely adhesive removers. So I did a little gentle spray with the adhesive removers, lifted up the steri-strips, cleaned things up, and then I just marathoned it. So you do a really gentle clean and then approximate the skin edges. And it really minimizes the amount of dressings you're going to have to do. Plus, of course, the person can shower. And also, you're going to reduce the number of home care visits when they're discharged, because he was nearing discharge. Let's look at this 80-year-old gentleman. He really enjoyed working with him. He was a volunteer driver for folks going for radiation to the cancer agency. And he fell, and he came up right afterwards to the clinic. He had sustained quite a skin tear, gave it a really good clean marathon, and off to the races he was. And again, minimal dressings, can shower. And interestingly enough, I've had a few of my patients talk about that there's not much of a scar thereafter. So can't explain that. I haven't done any big studies on that. But I want to once again go back to the literature and highlight some of the published work on skin tear management, both the prevention and management of skin tears. And this was just updated in 2021 from Wounds Canada. And there is a wonderful plethora of lovely resources from Wounds Canada on a variety of wound etiologies. And there is one specific to skin tears. So I just take a moment to highlight that. But actually, just this past summer, the UMA, which is the European Wound Management Association, they got together with ISTAP. ISTAP is the International Skin Tear Advisory Group. And they said, you know, we really need to highlight, let's dedicate a journal supplemental to skin tears, all the varying types of things that occur with skin tears. And so in that publication, I was really appreciative to work with them. And we've commented on the closure of type 1 skin tears using a cyanoacrylate. And so anyway, I just wanted to highlight that journal, the Journal of Wound Management, where there's all the articles are devoted to skin tear management and prevention, of course. So this 98-year-old lady, this one's an interesting case where, again, on the elbow, where again, I tried to position her, clean position, and then marathon it. By the way, I didn't do any questions with Mentimeter, so I'm going to go with a show of hands. How many of you in this room have used Marathon related to the skin tears? Can I see a show of hands? Okay, all right then. Something new, it's a little challenge. This is an opportunity to make some choices and maybe make some changes. And so this is how we apply the Marathon, and then you tend to have less dressing care. This one was interesting, and I was a little scared on this one. And of course, this elderly lady gave me permission, but it was on her face. So again, there was that steri strip. And so I carefully removed it. And, you know, this was helpful because you can see how there isn't much of a scar thereafter. And I think also walking around with a steri strip, although she did have a little bit of a purple line too. But anyway, you can see that the overall end result was quite helpful. And one time I listened to Dr. Kimberly LeBlanc, and I think she too included a case with a person on their face where very carefully the Marathon was applied when there was a skin tear. So interesting the different places you can use it. Now we're going to look at incontinence-associated dermatitis, another skin challenge, a painful one, where we're looking at how can relieve that exquisite, sharp pain that patients can experience, especially if they're having frequent stools. Now, I'm going to caution as we go through this next series of slides, there's a lot of bottoms. You're going to see a lot of bottoms, but that is the nature sometimes of IAD. And I just want to reassure you all that the patients all gave consent. But you know what I do? I find with patients who have wounds on their bottoms, more and more I'm doing this where I'll say, I'm just going to, you're okay. I'm going to take a photo. And then I'll say, would you like to see it? And more often they do. There are some who it's a flat no. And then a few weeks later, they'll say, can you go back to you told me you took a photo a few weeks ago. I kind of want to see that. But I strongly encourage, and I sometimes forget, but in the busyness of our work life, pressure injuries, it's just a must because it's such a teachable moment. And then there's an understanding because when they can't see it, and then they begin to see the progress, it's really, really helpful in terms of the patient engagement and their understanding of what's going on in that area. So let's take a moment to look at some cases. I had this 73-year-old with diarrhea and a weak anal sphincter. Barbara was a lady who had cervical cancer about 20 years ago and had had radiation. And as a result of that radiation, actually, she did not have bladder control. She's a very well-groomed West Van lady. And actually, she intermittently caths. So she's been we call her an intermittent cath user for probably 15 years. And that's how she empties her bladder. Well, as time went on, her anal sphincter was no longer working for her as well. And that was probably the effects of the radiation. And it didn't help, of course, that she had diarrhea. But when I met her, it was shortly after a flex sig. I think I'll stop there because I think we're going to include it in the video. We're gonna hear from Barbara in a few minutes, but this is when I first met her in endoscopy, when the surgeon called me and said, "Rosemary, can you come?" She said, "This woman says it's just so painful, has trouble sitting." And I mean, it was red, raw, weeping. And so we began Marathon. The fortunate thing about Marathon, it comes in a different size for when you use it with IAD. It's a different kind of a wand. You get more of the solution. And so I applied that. It dries in about 30 to 60 seconds. And then you can see 24 hours later. But I think more importantly, yes, is the skin, but it's the story from the patient, and that's 7 days later. So what we did with Barbara was actually Barbara needed a diverting colostomy. She said after a lot of thought, she was 75, she made the decision that she didn't want to wear briefs and constantly have that odor because she really had no control of her bowel movements. And what she would do is she regularly came to me for treatments about once a week until her colostomy. And then thereafter, obviously she didn't require any further issues there. But okay, so Damien, I think I'm gonna just see, Damien, if you could just go ahead and run the video clip, and we're gonna hear from Barbara as I talk to her.
Hi, Barbara. Thank you for taking a few minutes to share your story, a rather painful story for sure, related to managing issues with your IAD, or as we term it, incontinence-associated dermatitis. So, Barbara, my first question is, before I met you, you were struggling with not being able really to hold your stool coming out of your bottom, correct?
Yes, that's correct. And I had struggled for several weeks with ball incontinence. And so it made the anal area extremely red, raw, and sore.
Yeah.
To the point where I really could hardly sit, move around, because every time I moved, it would rub against the other skin.
Of course.
It was very, very sore.
I remember meeting you that first day because it was after I think you'd had a flex sig or something. Yes. And the surgeon said to me, "Rosemary, this lady has such terrible skin. Is there anything that you have that can make a difference?" Mm. And it just made me wince when I looked at it. And life had not been very.
No, it wasn't very good.
It wasn't very good. So I said, "Barbara, I've got this glue. I think it will help because it'll help the skin heal." Yeah. And I said, "But you know what? It's so bad. I'd like to see you in a couple of days' time." And then I've begun to follow you each week. So tell me about the differences pre the glue and versus after.
Oh, it was just, honestly, I thought it was like a miracle that had happened to me because, as you said, I went in for the surgery, and it wasn't that I hadn't spoke to my doctor, but of course with COVID, everything is virtual.
Right.
So, you say, "Oh, my bum is really sore," or whatever, but until the surgeon who was doing the procedure,
yeah,
actually physically saw it and realized how very bad it was. But she called you in even just after the procedure, and you took some photos and
Yes.
you put some of the glue on. And honestly, like I just can't tell you the difference it made to my life. It was
Yeah.
just incredible because it just allowed the skin to heal a little underneath.
Yeah.
I'm not saying that it's not sore,
Yeah.
but what a difference. It
Yeah.
was just.
I remember you were saying you were able to sit.
Yeah, I could sit again. And that was that was a big thing because of course, when in the previous time, the doctors would say, well, just go and get one of those rubber tubes. So my husband went to the drugstore, got one of these rubber tubes so I could sit. But it didn't really matter. I was leaning on my side. I was, you name it. Anything to not sit permanently down.
Exactly. So. I remember feeling relieved that I had this option because you came into Medical Day Center and you said, oh, wow, my life.
Yeah. It was like,
different.
It was so different. I was so grateful. Even my family said, oh my gosh, Mom, I don't know what they're doing, but just carry on.
Yeah. All right. Well, thank you so much for these few moments. Thank you so much, Barbara.
No
Great.
It's interesting. I have right now, I'll call it another Barbara, and her name is Sandra, and I'm looking after her right now, and she has fairly advanced cancer, but it's accompanied by really high bilirubin levels, and they're coming down as she's responding to the chemo. But the bilirubin stool and some of the frequency gave her terrible IAD. So she spoke to our oncologist. And so he gave me a call and said, look, is there anything you can do for Sandra? So I said, well, sure, we'll try something. And I kind of didn't want to build her hopes up because I thought, no, let's see. So put on the skin protectant. And, she phoned the oncologist the next morning and she said, it's the first time I had 10 hours of sleep. Because she said it was like I felt like I had glass, sharp glass coming out of my bottom. She struggled with fissures as well. So she as well, we're getting her bilirubin down. It's almost nearing normal levels. And so it was just a weekly treatment course. I will say though that, what I do after I apply the cyanoacrylate, I put also a very, very thin layer of the silicone Hydrogard on top, just in anticipation of her next stool. So when she's wiping, but she said, she's like Barbara. She wants to go on the news and tell people about it but it's such a private thing that you're struggling with. And isn't it classic how the doctor said to Barbara, get yourself a donut, go get a donut, get that ring. We hear that so often. Anyway, okay, I got to move along here. So those are, again, going back to the literature in terms of the prevalence of IAD. I'm not sure why, but I actually feel like I have been seeing a lot more of it. And, sometimes it has in the hospital setting does get confused with pressure injuries. But so I'll get referrals will say there's a coccyx pressure injury, and it's not a pressure injury. It's actually really IAD. And so there's so many options now that we can work with. I did also have another lady who, again, sphincter issues related to her spinal cord, and she had C. diff. And she was somebody who I did do my picture sequence and then showed her how her skin improved over the application of the cyanoacrylate. But this was another case I came across. It was a baby, and this was different because I'm always in my hospital. There's a pediatric component and a neonate area, and we had an NAS baby, and they often have very frequent liquid stools. I'm not sure how many of you come across the baby population, and so the traditional products were just not working. So we took the pains to do some cyanoacrylate, and lo and behold, discharged 5 days later, and there we go. So it was quite, it made a real difference compared to the usual products. And of course, you can imagine when they were even putting the creams on, the baby was so upset and crying. And so again, there was a much more contented baby in terms of having that covering in that area. So we've talked about peristomal skin damage, skin tears, IED, and now we're I want to just, there has to be an element where we talk about prevention versus treatment and how can we avoid some of the skincare challenges like this? And you just kind of think, oh, how did that happen? Well, in British Columbia, we went through a process of looking at all the various products on the marketplace. And we know through some of the work of Dr. Michael Gray that we want to cleanse, moisturize, protect when it comes to skincare. And by the way, I'm going to take a minute right now, and this is really, for me, it's really important. I want to mention to you the Click website. It's up and going, and we just recently changed the platform. So I should have put it on a slide, but it's clwk.ca. clwk.ca. Really cool. And that stands for Connecting Learners with Knowledge. And you'll see this big box: wound, skin, ostomy, continence. And you just, so, and some of the next slides of what I speak are, you'll find all of those resources on the Click website. And actually, I don't know, can you do that on the chat bar there? Oh, maybe for the virtual folks, we can make sure that they're aware of that website. So the before we in British Columbia, we looked at all the skincare products we had out there. There was well over 57 different products, different guidelines were being followed. And so we began to say, all right, what do we want in our skincare guidelines? And we said, well, it has to meet the clinical needs of our patients. We would love to do some standardization. We want it to be cost effective. And of course, it would be nice to have one skincare product line. But you know what, it was very important to us, particularly with WorkSafe BC, is they wanted the ingredients to be fragrance-free, safe, wax sensitizers. At the time when we were looking at this, there were some students, research students, who began to analyze the ingredients of all of these products and establish which ones were the ones that were paraben-free. And in fact, just recently, Shannon Hanfield, they just had the work done again, updated, confirming that indeed we're still very much on the right track in terms of the skincare line we have. You can imagine going from 57 different products down to a select few of about 5. And it also means, as a nurse or practitioner, a care aide, if you move from facility to facility, all using the same products, same protocols, they're paraben-free, fragrance-free, and they've actually been pediatrician tested, hypoallergenic. The first 3 is the foam, and it's got a surfactant cleanser. There's the moisturizer. So in our burn center, the moisturizer is used once your skin graft is healed and on the donor sites, and then the silicone HydroGuard. We enjoyed and appreciated those 3 products. So our province, our Provincial Skin and Wound Committee, approached Medline and said, look, we wouldn't mind having a body shampoo and cleanser that was also fragrance-free. Is there something that you have? And so Medline went back to the laboratory, and they now have created a body shampoo that matches that criteria. So, and I think we began to use that in 2021, and we're continuing to use that. But as a result of having that standard skincare protocol, it became very helpful when we were in the midst of the pandemic as to how can we help people, and again, be preventative as we were developing some skin issues with our protective garments that we had to wear. And so having that regimen, we could pull on the products that people knew well in terms of the moisturizer, et cetera. And so that was a quick, easy development, which is hard when the world is changing dramatically and you need to pull a document together in terms of standardization for the management of the issues related to gowning, gloving, masking, et cetera. So in terms of, as I summarize now, I want to say that exceedingly helpful taking the time in 2018, looking at our skincare line, adopting something that was relatively simple and very safe. And then also on that Click website, you'll see all kinds of teaching resources that we use for both long-term care facilities, acute care, and the community settings. In the end of the day, I believe those sorts of things, and also something like Marathon, very much improve the quality of life for many, diminishes suffering, and there's a cost effectiveness to when you can streamline and standardize approaches. And I think there's a more efficient use of product as far as just grabbing a variety of different creams on the shelf. How am I doing for time? Am I good? All right. Okay. So just want to make sure I touched on everything. Now, does anybody have any questions about anything related to the presentation or just anything? I'm open. Yes. Okay, so the question is around, once you use a cyanoacrylate around the stoma, how soon can you put the flange on? I think this is what your question is. Sure. And what I love about that is it's around 30 seconds to 60 seconds, because as you can appreciate with a urostomy, the urine is flowing. So you get it dry, and actually, yeah, you can put it on fairly efficiently thereafter. You know, it's a good question, but quite often it's a one-time application. One time. Yep, just once. And I usually tend to do it 24 to 48 hours after, if I get the call or the referral. People now know I'm kind of passionate about it, so I even get calls from Rosemary. It's a bump on the wheelchair, a bump on the bed, and it's a frail, elderly, fragile person. Go ahead.
Oh, hi, thank you very much for the presentation. It's nice to have another tool in our toolbox to use.
Yes.
And that's wonderful. One of the things that I do clinically, though, 50% of the time, I do contact dermatitis. And I don't know if anyone here in the audience is familiar with the Freestyle Libre story of all those patients wearing those cutaneous glucose monitors and the difficulty that we had in trying to identify what the allergen was, and the great difficulty that we had with the medical devices companies not being forthcoming with what was in their products. And just wanted to say that it was a glue. It was isoboronyl acrylate, and isoboronyl acrylate is a glue that is related to this. So I just wanted to say that just when you are treating your patients, we are putting these topical agents on open and broken skin. And that does increase the risk of developing contact allergy. So if you have patients that are doing initially really well, and then all of a sudden they start having problems and the dermatitis recurs, think that you could be dealing with an allergic contact dermatitis. And the risk of ACD, allergic contact dermatitis, from this chemical has been reported at about 3%. The risk of allergic contact dermatitis to parabens is 1%. So parabens gets a really bad rap, but as a contact dermatitis specialist, I don't often see positive reactions to parabens. So it's a great product. Keep it in your toolbox. It's really helping patients because irritant contact dermatitis is miserable. It's like the worst set of chapped lips that you ever had, but in worse areas. But do just be aware that if you see a worsening after initial improvement, just think about allergic contact dermatitis.
You know, very good comments. And you know, I've often sometimes wondered, because people say, are you worried a little bit about even trapping in any bacteria when you're doing that skin tear? So I do a full irrigation. And so I still go back. I have to go back. They've got this nasty contact, you know, either IAD or it's related to a skin tear. I haven't encountered that, but you know where I do encounter it a lot? It's with polysporin. Oh my goodness. I have seen
Polysporin,
some
yeah,
nasty
bacitracin,
contact dermatitis with
it's
polysporin.
8% of
Yeah.
patients will react to polysporin.
Yeah.
And if not the bacitracin, then some forms of polysporin will also have a numbing agent in it. And I've had like 5 patients in the last month in my contact derm clinic actually allergic to lidocaine.
Really?
So it's not
And
that the
you're-
products are
yeah.
bad. It's that
Yeah,
you
yeah.
have to be aware.
Just remembering that's another piece of it. Thank you very much. Is that Kim?
Maybe.
Ah, nice to see you.
Nice to see you too. Excellent presentation, Rosemary. Thank you so much. And just to echo what Dr. Parsons just said, one of the things that we do see a lot is that we will see kind of like people calling a rebound with the IAD, and we strongly suspect that it is a contact, like it's a dermatitis from the cyanoacrylate. That being said, it's in my toolkit. I use it all the time.
Ah,
Yeah.
yes.
My question for you is around how do you prepare your skin tears for using cyanoacrylates? And you know, one of the things that we do is we have strict protocols in place. And if the wound is more than 12 hours old, we won't use it for risk of increased infection. So can you tell us just a little bit about how you prepare
Yeah.
the skin tear? You don't just slap the glue on. I know that.
No. And in fact, I feel sometimes some of it is I've watched my plastic surgeons in terms of skin flaps, but I'm kind of really big on the irrigation. And we have our protocol for the Click websites that when it comes to wound care, you have to use over 100 mils. And so you have to use our 118 mil bottle of saline. So with the flap, I tend to do a very thorough irrigation. And then usually I have a sterile Q-tip adapter. And then I make sure that in terms of helping roll back that skin tear. And then simply applying the cyanoacrylate. But you know, I don't take it lightly, and I usually go back, or I get them to send me a photo. And then I usually, depending if they're on blood thinners, I sometimes will still apply a non-adherent dressing over that area because it's fragile, and secure it with cling. So I try to use no adhesives in that area. So depending on how much, if it's just happened, but you're right. I think the 12-hour, 24-hour window is sort of like stitches. A doctor will usually say, oh, it's past the window for me to do stitches. And I sort of kind of apply the cyanoacrylate in that same category. Does that make sense, Kim?
Yeah, that's what we do. We see this, and in Ontario, it's beyond the nurse's scope. So we actually need advanced directives and policy and procedure to be able to use it. Now, it hasn't been any problem getting us to put that in place, but it is important that we work within our scope. So, you know, for anybody, the cyano, I mean, they're fantastic. As you know, I'm like one of the world's biggest fans of using it for the treatment of skin tears. But I just think it's so important that we know you just can't run back to your practice and use it. You need to make sure that you have the knowledge, skill, and judgment to do so. You have the policies in place, and then go to it. But I think you need to protect yourself and make sure you have those things in place.
Do you want to make a comment on steri strips, Kim?
I think they're evil. So skin closure strips do have their place, but the problem is rarely are the wounds reapproximated enough. And then you have an entry point for bacteria. They continue to ooze and bleed. It blends into those steri strips. And then when you go to remove them, you actually end up causing more trauma. And this is, I mean, the International Skin Tear Advisory Panel, we did a huge survey on this at a global level. And, you know, we came back with the recommendation that they shouldn't be used on fragile skin. They have their place. I just
Mhm.
don't necessarily think in the frail elderly, that elderly skin, there's a place. But I could get shot for that. Thank you,
Thank you.
Rosemary. It's a
Thank you
great
very much.
presentation.
Hello.
Hi. Just wanted to ask a question about how you deal with, I have a client that has spina bifida. So they have those natural dimples in their skin. And we had one case where it started to break down and we didn't get it under control. So she ended up with quite like a 5 centimeter open wound tunneling in that area. And I'm just wondering if your product would be something that we could have used right off the bat that might have prevented that from happening.
I'm a person who I need to get the whole story and I need to see a picture, and I would be hesitant to commit to say, yep, go for it. But I would happy afterwards.
Okay.
You give me the information let me talk to you about what my ideas would be around that, because when I hear 5 centimeters, I'm going, oh, okay, a little bit more going on here. It reminds me, sometimes I'll get a picture of a diabetic foot ulcer, and I find if I can, I just need to see that person. There's just so much about a diabetic foot ulcer. I just need to see their shoe. I need to hear about their blood sugars. It's such a big picture versus just that wound. And so I will look for you afterwards, and let's see how I can help.
Great. Thank you.
Thank you, everybody. By the way, did the virtual audience have any questions? Go ahead, Shelley.
So I'm going to try to combine a few of them, but most of them were around how often do you apply the marathon, particularly on IAD?
I would have said IAD is usually twice. I'll go back in 24 to 48 hours, although the product itself can hold up for about 3 days.
Another question with regards to application of marathon, do you use it with each flange change?
I find it's usually always remember you're addressing the underlying cause. Why did this happen? Why did they have leaks? So I tend to do it once, they'll return, and there may still be little areas of denudation, and then I'll put it there. But generally my max application will be twice for somebody with really bad peristomal skin damage.
You put marathon without a dressing. Someone was quite surprised about that. What about for skin tears?
So depending on the size, yeah, there have been times where I've just laid it on a relatively small skin tear. But generally, as I was saying earlier to Kim, I'll put a non-adherent dressing over top and an absorptive pad and secure it with cling. I tend to avoid anything that has any adhesive, even if it is silicone. Their skin is usually so fragile and frail.
Any contraindications?
Do you want to answer that one? I guess.
It would be reaction to cyanoacrylate.
Right. And we've been mentioning how you can, as with many things, develop a contact dermatitis. So
is there a subsidized or compassionate program for marathon?
A compassionate program. In other words, something whereby people don't have to pay for it if they were an ostomy patient. I suspect that varies from province to province. We are getting some growing success in BC related to our pharmacare, actually in some elements covering the product. So there has been, and it's worth trying, but I think that's more of a based on each province and how your reimbursement plans are set up. Would that be fair?
Yes. I should also mention there are some private healthcare insurance plans that actually will cover marathon as well.
Yeah.
I asked a couple more questions. Going back to the IAD patient that you talked about, this virtual attendee was wondering what you use after the marathon. So once you finish the marathon, what did you use as a barrier?
We use again, staying with our skincare program, we use the silicone HydroGuard. It's a blue tube. And actually, I'm sure we'll have opportunity, maybe now even to go to the booth, you'll see the blue tube. of HydroGuard. So that is our go-to for people who, for whatever reason, are in disposable briefs or there's chronic incontinence. That's our go-to product.
Any further audience questions? Oh,
Hi, thanks for the presentation. I'm really enjoying it. The marathon, we actually use it quite a bit in our nursing home. You did say you put HydroGuard on after the application of it on the IUD?
I used to not want to. I used to think, I'm just going to use the marathon. That's it. But I have started because, you know, the person, sometimes they're having 6 or 7 stools a day. Maybe it's related to C. diff or sometimes an incompetent anal sphincter. So I feel like so yeah, I have done. And I don't know that it hastens the removal of the marathon in the days ahead. I don't think so. So my ladies, both Barbara and Sandra, they're my very cognitive, clear IAD people. They do a thin layer of HydroGuard over top. And that helps them as they have subsequent stools, like with Sandra with her stools with bilirubin. So yeah.
Okay, because we're finding that when the girls put HydroGuard on, sometimes it's removing more quicker.
Yeah.
We're usually doing it on their bath days and then.
I think also too, one thing I want to caution you is that when you do use it in IAD, it does take a good, you know, as I say, 30, 60 seconds to dry. Otherwise your butt cheeks will stick together a little bit.
Yeah.
So you know, you want to give that time to dry. And sometimes I'm afraid our world is, so that's where I have, as it's dried, but I don't want them to experience that stickiness. And that's where I'll do just like literally a very thin layer of the HydroGuard. But typically a bad IAD, I'm going back in 48 hours to look. And sometimes that's when I'll do my next application. But by that time, I'm having to sort out the cause, right? This shouldn't be something that you're doing all the time because you want to be dealing with the cause of why did the IAD occur in the first place.
Okay.
Thank you.
so I think we've come to our time today. Yes, there were many hearts from the virtual audience to you, thanking you for the presentation.
Good.
And on behalf of us at Medline, Rosemary, again, we'd like to thank you so much for sharing your expertise. It's always a pleasure to hear you talk and share, and particularly from a patient's perspective.
Sure.
So
Thank you, everybody.
thank you very much.
Right.